Ms. Chang, my name is Vicki Liang. I'm going to be your occupational therapist, and for today's session we're going to do a hand examination. So first I'm going to observe and palpate your hand, your wrist, and your forearm, and then we'll check your range of motion. And after that we're going to perform some tests that are commonly used to examine the nerves, the muscles, the tendons, and the ligaments of the hand, the wrist, and the forearm. And then we'll do some reflex and sensation testing. We'll begin in just a moment.
Okay.
When looking at the muscles of the forearm and the hand, you have the anterior or flexor compartment. In the superficial layer, you have first find the brachioradialis, and then there's the pronator teres, the flexor carpi radialis, the palmaris longus, the flexor carpi ulnaris, and in the middle layer, you have the flexor digitorum superficialis. This runs here and spans into 4 tendons. And in the deep layer, you have flexor pollicis longus. You have the flexor digitorum profundus that also splits into 4 tendons, and then you have the pronator quadratus. For the extensor or posterior compartment of the forearm and hand, you first have the extensor carpi radialis longus, extensor carpi radialis brevis, the extensor digitorum, which fans out into 4 tendons, the extensor digiti minimi, and then extensor carpi ulnaris. In the deep layer, you have the supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and then finally extensor indicis. Prior to doing the hand examination, you want to take a client's occupational history. You want to find out whether the injury is acute or if it's due to a chronic condition. If it's due to a traumatic injury, you want to find out what the circumstances were surrounding it. If the condition is not due to a traumatic event, you want to find out what the date of onset of the pain or symptoms were, as well as if there's any symptom fluctuations, if it seems to improve during a certain time or during a certain event, or whether it worsens, as well as the effects of the problem. So first, after taking the occupational history, you want to observe the hand, the wrist, and the forearm. You want to check for the nerves, the blood vessels, the temperature of the skin, the color of the skin, whether there are any stiffness or swelling or masses on any of the parts of the hand or the forearm. So first, observe both hands up to the elbow. Compare the color and the temperature of both sides, as well as the pulses on the radial and ulnar side. After that, you want to check for capillary refill by gently placing pressure on the tip of the fingers to blanch the fingertips. As well as on the nail bed. You want to find out if there is any infection or if there's any tumors or if there's any lymph nodes in the elbow area. And then after that, you would complete a range of motion test. So after doing an observation of the hand and the wrist and the forearm, you want to check the range of motion. So first have them extend their elbow and then flex it to touch so that their thumb touches the ipsilateral part of their shoulder. And then with their elbows tucked in at the body, check for forearm rotation, so pronation and supination. And then with the elbows on the table, check to make sure that they can flex and extend. And then with their hands on a surface to bring the fingers into flexion to touch the distal palmar crease where the MCPs lie. And then also to bring their thumb into opposition to touch the metacarpal head of their pinky, as well as each finger. Next, you want to check for tendonitis at the elbow, wrist, and hands. And to do that, you want to isolate the tendons that are problematic. So first, to test the lateral epicondyle, which is the common extensor origin, you can see right here, you would palpate there while the patient resists wrist extension. And a positive response would be if they feel pain while palpation and while resisting. And then to test the medial epicondyle here, which is the common flexor origin, you would palpate that while the patient resists wrist flexion. And again, a positive response would be if they feel pain during the palpation. There are 6 dorsal compartments of the wrist with tendons running in them, and they can become inflamed. For radial-sided tendinitis, the most common is de Quervain's tendinitis, which is inflammation of the extensor pollicis brevis and the abductor pollicis longus, which is housed in the first compartment. To test this, you would do Finkelstein's test, where your wrist is in neutral and then you hold the thumb and ulnarly deviate. If there is pain there, that is a positive sign. There's also intersection syndrome, where the first and second compartments overlap. And to test this, you extend the wrist and radially deviate while palpating 6 to 7 centimeters proximal to the radial styloid in the intersection point to test for pain there. Then there's thumb or digitoring, when you flex and extend the finger and it catches, and then you can feel a pop. You have pain in a nodule along the flexor tendon at the level of the A1 pulley of the fibro-osseous sheath, which is proximal to the MCP joints. Palpation to the area while patient flexes or extends the fingers elicits pain. There's also a feeling of clicking or triggering. When examining the wrist for flexi carpi radialis or flexi carpi ulnaris tendonitis, the wrist is flexed. You follow the flexor carpi radialis tendon, palpating at the carpal tunnel at the level of the scaphoid tubercle with the resisted wrist flexion. And this would elicit pain. And then to test the flexi carpi ulnaris, you resist wrist flexion and ulnar deviation while palpating at the level of the carpi ulnaris tendon. You also test the pisiform and triquetral joint. So to test that, you would test again with resisted ulnar deviation and wrist flexion while palpating the pisiform, grinding the pisiform into the triquetrium. Common tendinopathies include tendinopathy of the extensor pollicis longus. And to test that, you would resist thumb extension while palpating Lister's tubercle area to elicit the response. For the fourth compartment, which is the extensor digitorum, to test that, you would have the patient resist finger extension while palpating around the area of the fourth compartment to elicit a response. You can also check for tendonitis involving the tendon sheath of the extensor carpi ulnaris. To test this, you have the palm up, the forearm supinated, the wrist extended, and ulnarly deviating. You resist wrist extension and ulnar deviation while palpating the extensor carpi ulnaris tendon. You may also feel the tendon slipping over the ulnar head at times if they have the tendonitis of the extensor carpi ulnaris tendon sheath. When testing the carpal bones, the main structures are Lister's tubercle, the distal radius, the ulnar head, and the carpals. So to palpate the pisiform and triquetrium, and then distal to the Lister's tubercle, which is where the lunate is, to test for pain and ligamentous problems in the lunate triquetral joint. Next, you test while palpating the lunate and the scaphoid to see if there is instability or ligamentous injury. Also, if there's a suspected scaphoid fracture, you palpate in the anatomic stuff box, which is bounded by the first and third dorsal compartment where the waist of the scaphoid is, where the fracture usually occurs.